By the end of the module 4 of this dyspnea series, I'm sure you will feel more confident in having a structured approach of how to investigate a patient presenting with dyspnea, going through the common bedside investigations to the initial labs, proper imaging, and also sophisticated further imaging down the line, with clinical reasoning as a strong pearl supporting you. Plus, I'm going to discuss about the general management principles for dyspnea, and also we will go through some of the structured clinical patterns of dealing with the common clinical conditions ranging from pneumothorax to pulmonary embolism to heart failure, with strong emphasis on clinical reasoning. And I'm going to use, and with a soft launch of our MedEd trio, the Techie, the Brady, and the AU. So please stay tuned. So once you have taken the complete history and done the full thorough examination, and you've got a history and examination based differential diagnosis, let's come on to the investigation. So the first and foremost at the bedside will be pulse oximetry, ECG, capillary glucose levels, and peak flow for asthma and COPD patients. In terms of the lab investigations, obviously full blood count, looking for the anemia, hemoglobin, white blood cell count to assess any signs of infection. You would also like to do a basic or a comprehensive metabolic panel. Renal function, any renal failure can also contribute to cardiorenal syndrome or renocardiac syndrome and shortness of breath. C-reactive protein for an infection, lactate also to look at tissue oxygenation as well as part of sepsis infection workup. Cardiac troponins, when indicated, if you're suspecting acute coronary syndrome or a cardiac event describing the shortness of breath. BNP or N-terminal pro-BNP, whichever is available according to the local protocols for heart failure. And blood gases, either arterial blood gases if you're suspecting type 1 respiratory failure, or where you have to assess oxygenation of the patient, and a venous blood gas for a quick acid-base status when oxygenation or O2 saturations are not the high priority, for example sepsis, renal failure, etc. And the most basic and one of the most useful radiological investigations in a patient with dyspnea would be a chest x-ray, ideally a PA film, or if the patient is unable to mobilize and it's supportable, then an AP film should suffice. Now, after those initial battery of lab and radiological investigations, the next question would be what else in terms of specialized tests are required. And like any other investigation, one of the first things to ask yourself would be like a clinical reasoning question is, okay, why do I need this test? Will it change the management of the patient or disposition? If the answer is yes, then by any means we should discuss. Coming on to the special investigations, now let's look at the radiological. CTPA, you would always think about the pulmonary embolism as one of the causes for dyspnea. However, CTPA should only be considered if we have a clinical probability, so doing well scoring for pre-test clinical probability, and then if there is no other alternate explanation, for example the chest x-ray looks relatively benign and clear, there is no pneumonia, no heart failure, none of those features, and the patient is hypoxic, tachycardic, short of breath, pleuritic chest pain, or even normal chest pain, and there is no other plausible explanation, then yes, CTPA would be helpful. Always look at the renal function to make sure there is no contrast-induced nephropathy that you might be putting the patients at a high risk for. HRCT, high resolution, seldom required in acute dyspnea. However, a very useful investigation to look for the lung parenchyma for interstitial lung disease, complicated atypical pneumonias like organizing pneumonias. In terms of malignancy, you would rather do a full CT thorax with contrast rather than HRCT because the HRCT layers are thicker, so you might miss a small tumor or a small lesion. However, the resolution is high, so that's the difference between HRCT and CT. So the slices are thicker in HRCT, unlike the normal conventional CT thorax. Echocardiography, obviously if you're suspecting a cardiac cause, whether it's acute coronary syndrome, acute MI, you would like to look for the regional wall motion abnormality, or if it's a valvular heart disease, mitral regurgitation, aortic stenosis as one of the some of the causes of dyspnea. You would also want to see the pericardial effusion as a reason for dyspnea, plus also a strain pattern on echocardiography, and also left ventricular function in heart failures, HUF-PEF, HUF-REF, etc. Coming to D-dimer, wow, this is one of those tests which I don't know. To be honest, I personally do not think it's mostly very useful. It's only good if it's negative. So that means the sensitivity is high. So it's a good rule out test, but it's not a good rule in test. So the specificity is low. It's a very non-specific test. So you would only use D-dimer if the pretest clinical probability is either low or intermediate. So if the pretest probability well scoring is high, you don't need a D-dimer. However, if there is no other alternate explanation and you still think PE is a possibility, acute pulmonary embolism is a possibility, and the probability is low or intermediate, then a D-dimer would be useful, because if it is positive, then it supports the pulmonary embolism as a differential, and hence CTPA would be indicated. In terms of D-dimer, obviously if you have other conditions like pneumonia, sepsis, heart failure, malignancies, in all those conditions, unfortunately a raised D-dimer is not a very good test, because it could be raised due to so many other reasons, as we already know. So use clinical reasoning, clinical judgment, then decide about any of these other investigations. Further bedside investigations or immediate, obviously electrocardiography, ECG or EKG as they call it in the US, is extremely useful for cardiac etiologies like acute ischemic changes in acute coronary syndrome, acute MI, also sinus tachycardia or right ventricular strain, or S1Q3T3 pattern in acute pulmonary embolism. However, please remember an important exam question is for USMLE and MRCP part 1. Parts 1 would be the commonest ECG finding in acute pulmonary embolism, and that is sinus tachycardia. Only 10% of the cases with acute pulmonary embolism will have an S1Q3T3, like a deep S1, and the presence of a Q wave and T inversion in leads 3. So lead 1 and lead 3. So yeah. Also in terms of arrhythmia, atrial fibrillation, that can be due to any intrathoracic causes, any cardiac causes, that would also be a diagnostic clue towards the etiology for dyspnea. As I said earlier, arterial blood gas or venous blood gas can be an extremely useful investigation. ABG mainly to look at the oxygenation status if you're worried about oxygenation of the patient, for example acute asthma, acute COPD exacerbation, any etiology which can lead to predominantly type 1 respiratory failure. Also hypercapnia if you're assessing the CO2 carbon dioxide status, again in COPD, obstructive airway etiologies. Acidosis can be judged by both ABGs and VBGs. In fact, VBG is much better rather than a painful arterial blood gas tabbing for acid-base balance, metabolic, respiratory, and to look for any attempted compensation thereof. So both ABG and VBG can be an extremely useful investigation at the bedside, and really quick. Can give investigations the results and fairly soon, and can tell you a wealth of information before the actual lab investigations are back. As for arterial blood gas or venous blood gas, predominantly ABG, the purpose, as we said, is to look at the oxygenation, ventilation, and acid-base status. So oxygenation means O2 and PO2. Ventilation means looking at the partial pressure of carbon dioxide, and the acid-base status would be to look at the pH, bicarbonate, and base excess, etc. And also lactate to go with the tissue oxygenation and part of the acid-base status. I'm not going to go into the full details of ABG analysis, which will be covered in a separate module, how to interpret arterial blood gases. However, you need to follow a systematic approach. First look at the pH, whether there is acidosis or alkalosis, or is it normal. Then you look at the CO2. Is the CO2 high or low or normal, and is the CO2, the change in CO2 is compatible with the change in pH? If yes, then it's a respiratory cause. If it's not, then it's a compensation mechanism, if it's low or high. Then you look at the bicarbonate. Is a bicarbonate low, indicating acidosis? Is it high and indicating alkalosis, or is it normal? Again, change in bicarb should be in relation with the change in pH and CO2. And also look at the oxygenation for hypoxemia. As for arterial blood gas or venous blood gas, predominantly ABG, the purpose, as we said, is to look at the oxygenation, ventilation, and acid-base status. So oxygenation means O2 and PO2. Ventilation means looking at the partial pressure of carbon dioxide, and the acid-base status would be to look at the pH, bicarbonate and base excess, etc. And also lactate to go with the tissue oxygenation and part of the acid-base status. I'm not going to go into the full details of ABG analysis, which will be covered in a separate module, how to interpret arterial blood gases. However, you need to follow a systematic approach. First, look at the pH, whether there is acidosis or alkalosis, or is it normal. Then you look at the CO2. Is the CO2 high or low or normal, and is the CO2, the change in CO2 is compatible with the change in pH? If yes, then it's a respiratory cause. If it's not, then it's a compensation mechanism, if it's low or high. Then you look at the bicarbonate. Is a bicarbonate low, indicating acidosis? Is it high and indicating alkalosis, or is it normal? Again, change in bicarb should be in relation with the change in pH and CO2. And also look at the oxygenation for hypoxemia. So let's study the first example of ABG patterns with my favorite beetle. Okay, so the beetle is going to study the ABG patterns with you. So let's look at the pH. 7.25. What is it? Acidosis or alkalosis? Think about it. So it is acidosis. CaO2, CO2 I mean, PaCO2, carbon dioxide pressure. Is it high or low? 10. It's high. So this means there is CO2 retention. CO2 is an acidic gas. So if the CO2 is high and pH is low, which means the acidic gas is high, so it's a respiratory acidosis. Look at the oxygenation, PaO2, partial pressure of arterial oxygen. It's low, so it means oxygenation is also impaired in addition to the ventilation. What's the bicarbonate? 32. It's high. So this means the body is trying to compensate, because bicarb is not low, so it's not metabolic, it's respiratory. It's a metabolic compensation. So there is no metabolic acidosis as a cause. In fact, it's a compensatory response by the metabolic system of the body. Base excess is also high, +5. And the saturations, O2 saturations, are 86%. Again, it's important to know, is it on room air or on inside oxygen? So let's try to find an answer with our beetle. As we said, pH is acidosis, CO2 is high, PO2 is low, bicarb is high, base excess is also high, and oxygen saturations are low. So what's the answer? There is respiratory acidosis, no doubt, because CO2 is high and pH is low. Is it compensated or uncompensated? It's uncompensated. Yes, bicarb is high, so there is an attempt to compensation, but the beetle knows that pH is still low, so it is uncompensated. What are the causes? Predominantly COPD and neuromuscular weakness, like Guillain-Barré syndrome or any other neuromuscular diseases. Okay, so now the beetle is going to study the second scenario. Okay, so what's the pH? 7.18. Is it acidosis or alkalosis? Obviously it's acidosis, because the pH is less than 7.35. Let's look at the CO2. The CO2 is normal, so there is no compensation, or no mechanism contributing to the acidosis. Neither there is any compensation, so it's unlikely to be a respiratory cause. Let's look at the PaO2. Oxygenation is normal. The bicarb, it's low, 12, so it means it's metabolic acidosis. And base excess is also -14, and saturations are normal. So now we will find out the answer to this. So obviously it is uncompensated metabolic acidosis. Why? Because there is acidosis, and it's metabolic because bicarb is low. It's uncompensated because carbon dioxide is still high, still normal, so it should be low too, because it's an acidic gas. So if the CO2 is low, it means the body is trying to compensate for the acidosis by blowing off the acidic gas. And in the longer run, bicarb will be accumulated, so that's the later compensation. So it's uncompensated metabolic acidosis. What are the causes, beetle? The causes could be diabetic ketoacidosis, lactic acidosis, acute kidney injury, and also any cause of bicarbonate loss, for example gastrointestinal loss due to diarrhea and vomiting, profound diarrhea and vomiting. So that's it. Okay, so just a little bit about chest x-ray we discussed earlier. So the typical causes of chest x-ray abnormality for dyspnea would be anything to do with parenchymal lung disease or involvement of lung parenchyma, like acute pulmonary edema due to heart failure, pneumonia or tuberculosis, and also lobar collapse or partial atelectasis or complete atelectasis for that matter. This is the lung parenchyma itself. So please refer to module 1 of the causes of dyspnea, in which I have gone through the detailed of how the air goes through the airways into the lungs and from parenchyma outwards towards the periphery. Then out of the parenchyma, if you go on the side, you are talking about the lung surface, which is the pleural lining. So anything to do with pneumothorax or pleural effusion, those would also be visible on a chest X-ray. However, a caveat before saying a normal chest X-ray would be a very subtle apical pneumothorax. So it has to be looked at in real high resolution and inverting the chest X-ray control, the resolution, the flipping the black and white color intensity, color contrast, so that would lead to better visualization of the apical pneumothorax. And some of the limitations for a chest X-ray are that very subtle or earlier interstitial lung disease may not be visible on chest X-ray, almost like 10% of the cases. Bronchiectasis, again, especially earlier on, can be easily missed. So you may have more signs and the auscultatory signs and the radiological findings of bronchiectasis on chest X-ray. Similarly, airway disease like asthma or COPD may not have any radiological signs unless associated with pneumonia or infection. However, in COPD, you might have hyperinflated lung fields where you can count more than 6 anterior ribs. So we'll come to that in our chest X-ray module. So please stay tuned. There will be a separate module on how to read a chest X-ray, but these are some of the important findings that you need to think about. So now I have my maroon beetle with me to read about acute pulmonary edema on the chest X-ray. So beetle, it's going to ask me about some questions. So the beetle is asking me what would be the findings of acute pulmonary edema on a chest X-ray, and we know that some of the features could be alveolar edema and that's why it leads to bat wing appearances, because the bat wings are radiate from the center of the body and they just span out, so there will be more centrilobular edema spanning out. Then you would have curly bee lines, beetle, which are interstitial edema findings, especially in the middle zones. You will have cardiomegaly, but for that to be assessed, you need a proper PA film, and if the cardiothoracic ratio is more than 50%, more than 0.5, that would strongly indicate cardiomegaly. You would have dilated blood vessels, so cephalization. Normally the upper lobe vessels should not be properly visible, so if there is upper lobe diversion, which means these are anti-gravity blood vessels, and if there is high end diastolic pressure in the in the heart, that will lead to back pressure, and hence the upper lobe vessels will be predominantly visible, which would normally be not visible. There could also be elements of effusion, pleural effusion, which can be bilateral, or in a lot of cases it can be unilateral. So the beetle has learned some good findings about acute pulmonary edema on a chest X-ray. Good. Now, having learned the heart failure findings, the beetle would like to know about the chest X-ray findings of a pneumothorax. So beetle is curious, how would a pneumothorax look like on a chest X-ray? So the answer to that is depends upon the size of pneumothorax. However, some of the diagnostic clues would be a visceral pleural line, which means that the parietal, obviously there is a massive air between parietal and visceral pleura, which should not be present normally. So there will be a sharp white line of the visceral pleura which is abutting the lung parenchyma itself. So there is a sharp visceral pleural line. Beyond that, the lung markings will be devoid. So there will be no lung markings, hence no vessels visible in that space, because that space is now all air and the whole pleural space is filled with air. So there is no lung tissue over there, hence you cannot track the vascular markings right up to the edge of the lung. Obviously depends upon the size of pneumothorax. And in tension pneumothorax, there will be a mediastinal shift. What's the learning point? If you're suspecting a tension pneumothorax, we discussed in our module 2 and also module 3, please do not wait for a chest X-ray if it's a tension pneumothorax. Time is of essence, and hence draining in the mid-clavicular line, second intercostal space is literally life-saving. So that's about chest X-ray in pneumothorax. So now the techie beetle would like to know about incorporating arterial blood gases in chest X-ray, because the beetle has learned about the chest X-ray and the ABG so far. So in terms of pattern recognition, if you have COPD exacerbation, you can expect type 1 respiratory failure or type 2 respiratory failure, or any combination of both. Plus, on a chest X-ray, you can expect hyperinflated lung fields, and clinical examination wise, you can expect some wheezing. In terms of pulmonary embolism, you would predominantly expect a hypoxemia, type 1 respiratory failure, and because of the respiratory drive, there will be tachypnea, and hence you might have respiratory alkalosis and relatively normal chest X-ray. Okay, and that would indicate a high risk patient. In acute heart failure, the tachy beetle can expect pulmonary edema on the chest X-ray, elevated BNP or pro-BNP on lab findings, and a raised JVP and lung crackles. So coming to the radiology for chest CT protocols, don't worry, I've got some nice colleagues. It's actually a quartet, and it will be a MedEd quartet, which I'm going to introduce later. So chest CT protocols, first of all, HRCT indicated for conditions like interstitial lung disease and bronchiectasis. Advantages are no contrast is needed, but the disadvantages are that it's not useful for conditions like if you're suspecting lung carcinoma or a lung mass or a lesion. While the CT thorax in contrast will be used for this particular precise reason, if you're suspecting underlying lung cancer or a mass lesion. Also, if there is a lobar collapse and the diagnosis is uncertain, or non-resolving pneumonias, pleural effusion of undetermined significance, and mesothelioma. Similarly, we discussed the role of CT pulmonary angiogram, which is a contrast study. The key indication will be suspected pulmonary embolism, most likely acute, sometimes also chronic, and also history of or suspicion of pulmonary hypertension, as in chronic PE, and also sometimes due to cor pulmonale, right heart failure, or conditions like obesity, hyperventilation syndrome leading to pulmonary hypertension, or it could also be just idiopathic. Coming on to cardiac investigations, echocardiography. The key indications would be to diagnose cardiac failure, especially if there is no previous history or suspicion. Suspected valvular disease, you want to look at the valve etiology, valve morphology and functional status. Also cardiomyopathies. In emergency situations, a massive pulmonary embolism can also be identified with the right ventricular strain pattern on echocardiography, and also including shocked patients. Plus also pericardial effusion or tamponade when it is suspected. We discussed in modules 2 ED approach, so please refer to that. So echo is extremely essential, especially bedside, a quick focus. In terms of respiratory function tests like spirometry and peak flow assessment is helpful in acute settings, especially if the previous best personal peak flow is known. Then you can compare the deterioration, and it also guides us in discharging the patient when they have achieved almost 80 to 90% of their personal best peak flow. Otherwise, spirometry is not indicated and usually not very helpful in acute settings. However, once acute flare-up of infection, COPD or asthma is stabilized, then in about 4 to 6 weeks time it can be done. And the role of spirometry and also peak flow is basically for diagnostic purposes, and we cannot diagnose it usually in acute settings when there is an inflammation or acute etiology. However, in 4 to 6 weeks time, when the acute infection and acute episodes resolve, then it can be done by pulmonology team as an outpatient, and mostly in cases where there is diagnostic suspicion or the previous history of COPD or obstructive airway disease has not been diagnosed, which is fairly common. Sometimes they've been started on inhaler for no reason, and hence a formal objective diagnosis of obstructive airway disease or restrictive airway disease, whichever the pattern may be, can be made using spirometry and lung function tests. Pleural fluid analysis can be an extremely useful investigation during presentations with dyspnea and patients with pleural effusion. Obviously, the key diagnostic framework will be to diagnose exudative versus transudative effusions, or if you're suspecting empyema. The protein analysis gives us, it's one of the criteria, and the Light's criteria for exudative versus transudative. If there is high protein level, obviously that indicates it's exudative, related to infections, inflammations, etc. Microbiological assessment is crucial for cultures and sensitivity suspected of infective pleural effusion or empyema. Also tuberculous cultures, TB cultures, and PCR if there is a high suspicion of tuberculous pleural effusion. pH testing can give a quick result of either pneumonic effusion or empyema if it's below 7.2. and pleural fluid cytology, although positive in just around half of the cases, but again can provide a useful clue towards the diagnostic patterns of malignancy. And if it's blood sustained, it is blood stained pleural effusion, then cytology may not be that reliable. Just a quick word about the Light's criteria for pleural effusion. As we discussed earlier, it's mainly to differentiate between transudative and exudative. The key feature is the leakage of protein. In exudative fluid, there will be more protein. So if there is a serum, if there is a pleural fluid and serum protein ratio above 0.5, or pleural fluid LDH and serum LDH is the ratio is above 0.6, or if the pleural fluid LDH is more than 2/3 of the upper normal limit of the serum LDH for that particular lab or institution, then it is indicative of exudative pleural effusion. And some of the commonest causes for exudative are infections like pneumonia, pneumonic effusions, malignancies, any etiology like lung, breast, or lymphoma, pulmonary embolism, tuberculosis, and also inflammatory conditions like all the connective tissue diseases, rheumatoid, pancreatitis, which can lead to exudative pleural effusion. So these will be the causes of exudative pleural effusion. Very important exam questions, really crucial in USMLE, OSCE, and MRCP exams. Now, in terms of bronchoscopy, not every patient with dyspnea will require a bronchoscopy, but some of the diagnostic indications for dyspnea would include if whenever there is a suspicion of airway obstruction, especially middle up higher to middle level airway obstruction, or if there is a localized wheezing, which could also indicate a partial obstruction or a complete of one of those larger airways, which leads to monophonic wheeze, especially monophonic wheezing, which is localized in one particular part. Or if there is a persistent recurrent pneumonia which is not resolving, so that would be one other diagnostic indication to look for any endobronchial lesions. Sometimes if there is tracheobronchomalacia, it cannot be diagnosed without a proper bronchoscopy, because the collapse of the tracheobronchial tree will only be visible on bronchoscopy, so that can become a diagnostic clue. When there is a diffuse lung disease, for example organized pneumonias, then bronchoscopy can provide diagnostic bronchoalveolar lavage, and hence some of the atypical organisms can be picked up on the diagnostic bronchoalveolar lavage done during the bronchoscopy. Similarly, bronchoscopy can also be used for therapeutic indications like removal of foreign bodies from upper airways, which can lead to atelectasis. Also, mucus plugging in elderly patients, if there's thick tenacious mucus which leads to atelectasis, that can be aspirated in bronchoscopy. If there is a tracheobronchomalacia or any collapse of part of the airway, then airway stenting can be done. Tumor debulking and ablation, depending upon the staging of the tumor. So if there is a multidisciplinary team outcome suggesting that palliative removal or palliative debulking of the tumor can also be attempted, so that's another indication. Coming to the exam tips, exam corner for the investigation. So for this we will be using our the MedEd trio, which are part of the MedEd quartet, as I said before. However, here the trio role is crucial. So the red beetle is our techie, this is our Brady, the green turtle, and the gold beetle is the gold standard. So techie is system 1, which instantly gives or comes to the intuition, while Brady, the turtle, thinks about the slow and calculated analysis, and eventually both are leading to the gold standard, which is the evidence of the diagnosis. Now, if you look at the selection of investigation, so whenever you come across with an MRCP part 1 question or USMLE or OSCE, think of the single best next investigation. Do not think about the best for the condition, think of the best for the patient in question. So it may be that the chest X-ray may be the best initial investigation rather than the CTPA or CT of the lung. So the selection has to be based on the best scenario. So that's where the intuition comes into play, but you should always think about the evidence. So the red beetle would say yes, CT, but your analysis part, the green beetle, which is the Brady, will think about deeper analysis, and eventually both will lead to the diagnostic clue, which is a gold standard. Now, same is about the clinical presentation. Avoid the long details. Whenever you have an OSCE or a MRCP paces clinical examination for the respiratory system. Think of a structured approach, arterial blood gases, chest x-rays, investigations, etc., rather than rushing towards the bronchoscopy and all the advanced investigations. So think of it like a normal case scenario when you are seeing a patient in an emergency department or a clinic. How would you proceed? So that's again, it's again, the evidence is not the techie nor the bready. So you have to think about both systems in unison. So think, pause, calculate. In terms of justification, you need to identify that each investigation, what is the evidence? So that's where the evidence, the gold beetle, the AU, which is aurum is the chemical name for gold. So the AU will, the gold beetle will tell you the best investigations, best evidence for that particular condition. So each investigation has to be backed by an evidence. So let's say if we have pulmonary embolism, you want to do CT pulmonary angiogram, you don't jump straight to CTPA, you need to look at the pretest probability and think of all those conditions which can lead to pulmonary embolism, whether the CTPA is really justified or not. So these are some of the important exam tips for OSCEs or MRCP or USMLE exam with the help of our MedEd trio. Now coming to the management part of acute dyspnea or dyspnea, any patient with dyspnea. Always remember A, B, C, D, E approach. I've touched in our module 2 and 3 in extensive detail, so I'm not going to go into all those steps again, but please do refer to those modules. Once you have stabilized the patient, then you need to look at the patient's positioning, monitoring, and also other parameters that we will discuss shortly. For the next 2 slides, I'm going to pick up these 2 slides from our module 3, so please stay tuned. OMIV stands for oxygen, monitor, IV access, and vitals. Oxygen, titrate according to requirement, but as high as possible if it's appropriate. Usually a target is 94 to 98, except COPD when it could be 88 to 92, you can lower it down. Monitoring, immediately attaching the cardiac monitor for rhythm, and also peripheral pulse oximetry for saturations and blood pressure monitoring as appropriate. IV access, ideally 2 large bore IV access for immediate immediately securing vascular access in case there's a peri-arrest situation. So you should not be losing the critical vascular access, either a green or a gray Van Fleon. Size 18, 16, 18 gauge, the higher the better. In terms of, and last is a V, vital, so baseline neurological status, temperature, respiratory rate, and also blood pressure, but keep monitoring frequently. That is a key thing in this situation. First principle, oxygenation. Normal target should be above 94%, 94 to 98. The only exception will be in COPD patients who have got chronic type 2 respiratory failure. Their respiratory drive is driven by hypoxia rather than hypercarbia, because high CO2 leads to the respiratory center becoming desensitized. So if you remove the hypoxemic drive with too much oxygenation, that can lead to respiratory depression and worsening of the type 2 respiratory failure. So in COPD patients, the ideal saturation level will be 88 to 92%. In terms of positioning, most patients with dyspnea, sitting upright will be the key thing, because you are improving the diaphragmatic excursion. Otherwise, lying flat or semi-supine will lead to diaphragmatic splinting due to the abdominal viscera pressing upon the diaphragm. So sitting upright increases that functional residual capacity, tidal volume, and also especially in anyone with who is on non-invasive ventilation, you need to use the diaphragms properly for their for the vital capacity and ventilatory mechanism. The next, which is already part of OMIV, is an IV access. So immediately get ideally 2 IV access, 2 lines, preferably a gauge 18 or 20 at least, and do the bloods at the same time. And you can do VBG or ABG. ABG will be from arterial access, obviously from radial, and the IV line will be in the venous. But if you just want to do the VBG, you can take the same blood from the venous access. Before we go to disease specific or condition specific management, oxygen prescribing. If there is type 1 respiratory failure, which is hypoxic, in conditions like pneumonia, pulmonary embolism, asthma, or pulmonary edema, then the target is usually 94 to 98% except COPD. We will come to that. That's a type 2 respiratory failure. The device is usually you will start off with nasal cannula, depending upon the flow rate, up to 2 to 3 liters, maximum 5 liters per minute through nasal, because after that it starts to dry up the nasal secretions and it's quite uncomfortable and doesn't improve the inspired oxygen delivery. If that is the case, you can also start off with Venturi masks, controlled 24%, 28%, 35% if needed. And eventually, if the oxygen requirements are still high, you can use a non-rebreather mask. Similarly, in type 2 respiratory failure, predominantly due to COPD or neuromuscular conditions or obesity, hyperventilation syndrome, as we discussed before, patients are very susceptible to a worsening of the type 2 respiratory failure due to the suppression of the hypoxemic drive. So we need to be very strict with target saturations of not more than 88 to 92%. It's a very tight range. And the ideal way of delivery to ensure this delivery will be through controlled Venturi mask, either 24 or 28%, guided by the arterial blood gases. So in this situation, precision is really the key. One recent novel mechanism of oxygen delivery has been the high flow nasal cannula oxygen or high flow nasal oxygen, HFNO. During COVID, it has tremendously helped in reducing the need for non-invasive ventilation or even ventilation for the or invasive ventilation for the patients with COVID pneumonia, especially in younger patients. So high flow nasal oxygen can be used which can deliver up to 60 liters per minute of oxygen, and it helps in providing the strong PEEP effect, like it's because of the high pressure it leads to opening up of the distal alveoli and hence improves the oxygen delivery and also reduces the dead space, so there is better alveolar arterial oxygenation delivery. Now, in terms of the non-invasive ventilation, there are two different types. One is the continuous positive airway pressure, the CPAP, and the other one is the BiPAP, which is bi-level positive airway pressure. In terms of the CPAP, it's indicated usually in type 1 respiratory failure, especially due to acute cardiogenic pulmonary edema. The mechanism involves the splinting of the airways open. So if there are distal collapse of the airways due to the continuous positive airway pressure, which is maintained throughout the respiratory cycle, ventilatory and respiratory cycle, it leads to more recruitment of the collapsed alveoli and hence leads to better oxygenation. And also due to the positive pressure, the fluid inside the alveoli is also pushed out, mechanically pushed out, and hence leads to better oxygenation. And the normal settings are usually around 5 to 10 centimeters of water. Usually lower settings are started, assess the response with blood gases and patient's tolerance, and then gradually the pressures can be escalated. Similarly, as for the BiPAP, the bi-level positive airway pressure, there are two separate pressures, IPAP and EPAP. IPAP is to help with the ventilation support, so it's inspiratory positive airway pressure, which leads to better tidal volume and increased minute ventilation, and it also assists the inspiratory muscles, and hence the muscles are more relaxed. So by doing all this, the minute ventilation is improved, that leads to better ventilation and hence the CO2 is blown off. In terms of the EPAP, the expiratory positive airway pressure, it recruits the distal, it keeps the positive pressure at the end of expiration, hence it leads to the better functional residual capacity, and the alveoli stay open during expiration, and hence it leads to better oxygenation. So both EPAP and IPAP are essential in adjusting the CO2 and O2 levels as per the blood gas analysis. Now, the primary indication for non-invasive obviously would be for type 2 respiratory failure due to COPD, and especially if it's decompensated and leads to respiratory acidosis with a pH of less than 7.35. In terms of contraindications, because it's a tight fitting mask, anyone with low GCS or vomiting or facial trauma, it will be quite difficult, and sometimes the patients can be quite claustrophobic. So in such settings, you can start off with lower pressures, and maybe the mask can be slightly loosely fit rather than too tight, and then once they acclimatize better, then gradually the pressures and or the fitting of the mask can be adjusted. Now coming to the condition specific management, because it's extremely extensive, you can discuss about each condition in too much detail, but I'm going to keep it very focused about some of the key common conditions. So the first one is anaphylaxis management. Please refer to module 2 and 3, especially module 2, the ED management of anaphylaxis, the first 15 minutes, so that's really crucial. The key principles are intramuscular adrenaline, IV fluids, and steroids. So adrenaline is a very important exam question, or epinephrine has to be in 1 in 1000 concentration, half a milligram or half or 0.5 ml, the same thing. And for adults, it's given in the biggest muscle, usually the thigh muscle, and if it can be repeated every 5 minutes if there is no response. Because there is a usually vasodilatation and circulatory shock, so a massive amount of fluid resuscitation might be needed. Usually speaking, 500 to 1 liter bolus as any crystalloid stat, and reassess according to MAP and lactate and clinical response. Adjuncts will include intravenous hydrocortisone, a big dose, 200 milligrams as a stat dose, and also antihistamines like chlorphenamine IV injection, followed by nebulizers if the patient is wheezy. Obviously, it depends upon patient's condition, but these are the general management principles for anaphylaxis. And don't forget the ABCD approach and OMIV, all of them. I'm just talking about the specific management steps, assuming that all the stabilization measures have been done as discussed in modules 2 and 3. Similarly, for pneumothorax, please refer to module 2. I keep referring back to the other modules because that is the right thing to do. There is so much detail. However, for pneumothorax, you need to make sure there is no tension pneumothorax. If there is a tension pneumothorax, you do not need a chest x-ray. It has to be a clinical diagnosis. Tracheal shift, mediastinal shift, hemodynamic compromise, patient is extremely ill and totally absent breath sounds on one side. Needle thoracocentesis, as simple as that. So needle decompression for that matter, and then thoracocentesis with the proper surgical drain after that. So make sure there's expertise available, anybody who can do that or who has clinical privileges to do that. In terms of spontaneous pneumothorax, depends whether it's primary without any underlying lung etiology or secondary. Please follow your local guidelines, but generally the general rule of thumb and from BTS guidelines and American Thoracic Society and most of the European Society guidelines, in the primary pneumothorax, if it's small, less than 2 centimeter rim, then you don't need to do anything. Usually observation, supplemental oxygen, serial chest x-rays, and a follow-up should suffice. However, if there is more than 2 centimeter or breathlessness, then or if the patient has got symptoms, then it might need needle aspiration. In terms of secondary pneumothorax, anyone with underlying lung problem like COPD, then less than 1 centimeter, small, tiny, less than 1 centimeter oxygen, you need to admit them and just provide supplemental oxygen and observe. But if it's more than 2 centimeter, then a proper Seldinger chest drain may be needed. Again, I keep saying this, please follow whatever your local policies or local guidelines according to your institutional policies are. Similarly, in acute pulmonary embolism, from management point of view, please remember all the ABCDE approach and the OMIV. I'm just going to discuss about the specific points. So if it's a high risk or a massive PE suggested by shock or hypertension, then the immediate treatment would be thrombolysis, either alteplase or embolectomy, mechanical embolectomy, and supportive care is needed for fluids and ICU care usually. Intermediate risk, whenever there is RV strain, troponin release, one of the key principles in this stage management will be admission to high dependency unit or coronary care unit, whichever the case is locally. Anticoagulation in the form of DOAC or low molecular weight heparin is indicated, and monitor for decompensation. If it does decompensate, then thrombolysis or thrombectomy will be indicated. In terms of low risk acute pulmonary embolism, patients are usually, if they are stable, then they can be anticoagulated with either a low molecular weight heparin like enoxaparin or DOAC, and preferred DOACs currently are rivaroxaban or apixaban. Once again, use whatever your local center recommends. And early discharge planning is possible based on the pulmonary embolism severity index scoring. Management of acute pulmonary edema after ABCDE and OMIV, the specific actions are indicated by a nice mnemonic LMNOP. The first 3 are pharmacological and then oxygen and positioning. In terms of pharmacological, L is for Lasix, which is furosemide. It's a diuretic, but the immediate effect is venodilatation, reduced preload, and hence better oxygenation, and the fluid is sucked into the pulmonary vasculature from the alveoli. Diuretic phase can take 15 to 20 minutes, and eventually it can the peak effect can be in 1 to 2 hours, so that is a later response. Morphine used with caution. A gentle dose of morphine or diamorphine can reduce the intense respiratory distress and the anxiety and help a patient to settle down. However, excessive use can lead to further respiratory depression and leads to worsening of the oxygenation, so use it with caution if at all. Nitrates, same mechanism, vasodilator, immediately improves the oxygen delivery and sucking of the fluid from alveoli into the pulmonary vasculature. In the UK, when I used to do the training, I remember the patients were extremely sick. Acute pulmonary edema is one of those conditions which frightens you as a trainee. And I remember the moment you put them on high flow oxygen, give a gentle dose of morphine, and just a couple of sprays of sublingual GTN spray. Within 5 to 10 and a shot of Lasix, but on these 3, 4, 5 steps would just drastically reduce or improve, drastically reduce their anxiety level, improve oxygenation, and within 10-15 minutes when you come back they were a different patient. So nitrates, same mechanism, quick action, vasodilatation. High flow oxygen, do not worry here about type 2 respiratory failure, COPD, because oxygen delivery is a crucial thing here. Unless you are dealing with somebody with severe type 2 respiratory failure, then you can titrate accordingly. And positioning, you have to sit them up. As we said before, you need the diaphragmatic excursion to help with the tidal volume and to improve oxygenation and to blow off the carbon dioxide. Role of NIV, we discussed before, continuous positive airway pressure. It can be a silver bullet. If it's initiated earlier, it does the same mechanism but in a mechanical way. So the fluid inside the alveoli can literally be pushed out into the extra alveolar space because of the shear pressure exerted during the continuous inspiratory and expiratory phase, and reduces both pre and after load and reduces the work of breathing, assists the ventilatory drive. That's why it's called non-invasive ventilation. It's assisted ventilation. But if it started earlier, it helps in management of the patients with acute pulmonary edema. In terms of acute heart failure, usually speaking, for uncomplicated simple cases, after stabilization in emergency department, they should be relatively straightforward for management on general medical floors or acute medical assessment units. However, if the cardiac failure is refractory to treatment, or if there is a serious organic etiology with cardiac causes established or suspected, then specialist referral to CCU, cardiology, or high dependency unit or ICU may be indicated. In terms of the refractory pulmonary edema to medical treatment, again, non-invasive ventilation we discussed like CPAP will be crucial. Inotropic support for cardiogenic shock may be indicated if it's primarily a cardiogenic shock. Mechanical support like intra-aortic balloon pump or left ventricular assist devices, again, if it reaches to that point, the patient will likely be in coronary care unit or CICU. In terms of the precipitants, there is good mnemonic for general physicians, which is CHAMP. So acute coronary syndrome, so C for coronary syndromes, hypertensive emergencies, arrhythmias, which are likely precipitated due to cardiovascular problems, mechanical causes like valvular ruptures, and severe pulmonary embolism, which require thrombolysis. So these etiologies can precipitate acute heart failure, hence necessitating high dependency or specialist referral earlier on. Now, for the management of acute asthma, the mild exacerbation of asthma can usually be managed out of hospital in communities by the GPs or primary healthcare physicians. So usually the peak flow is above 75% of the personal best. They do not require oxygen, and usual increased use of the normal inhalers plus minus steroids should do if it's a non-infective exacerbation, and that's usually self-limiting. In terms of the hospitalized patients who usually have moderate, severe, or life-threatening asthma, in terms of moderate severity, the peak flow is usually 50 to 75% of the personal best. That's why it's really crucial to ask the patients about their personal best peak flow rate or PEFR. The treatment management protocols in such patients will be nebulized salbutamol. Usually single nebulizer is like one type of pharmacological agent is enough, or you can combine even with ipratropium. Oral steroids, prednisolone, a short course, 30 to 40 milligrams depending upon, or up to 50 milligrams depending upon the patient's body habitus, for up to 5 days, or sometimes up to 7 days if really needed, but 5 days should be more than enough. And oxygen as needed to titrate it to SATs of 94 to 98%. In terms of severe asthma, when the peak flow is 33 to 50% of the personal best, or if there is severe tachypnea, respiratory rate of above 25, or tachycardia at heart rate of above 110, these indicate severe exacerbation of asthma. So back-to-back nebulizers, both salbutamol and ipratropium, are crucial. A stat dose of intravenous hydrocortisone is quite good, around 100 to 200 milligrams, and then you can either continue IV steroids for 24 hours or you can switch to oral depending upon the situation. Intravenous rapid magnesium, 2 grams, given over a short period of time like 15 to 20 minutes, diluted in either normal saline or 5% dextrose, immediately reverses the bronchospasm. That's the key thing here, and can be repeated again if needed. So this is for, and monitoring of the peak flow for severe exacerbation. Usually within 24 hours the response should be noticeable. Now the signs of life-threatening acute asthma are that if the patient has got a silent chest, please refer to module 2. I keep saying that, in that we have discussed about the life-threatening etiologies, and one of the signs is a silent chest. Or if there is a cyanosis, hypotension like hemodynamic compromise, and also a normal PCO2. The reason is because in asthma patients they are hyperventilating to try and compensate for the hypoxia. So their CO2, usually due to hyperventilation, the CO2 should be low. But if you have a patient with a hypoxia and a normal CO2, that should ring alarm bells. So immediate ICU intervention, airway support, maybe invasive ventilation may be needed, and sometimes the salbutamol and aminophylline can be given IV. But once again, depending upon your local center priorities, preferences, policies, please follow them. And this is a general guide. It's not a one size fits all. But these are the general principles of management of acute severe asthma in hospital settings. Similarly, for acute COPD exacerbation after stabilization, the key pharmacological measures would include bronchodilators, salbutamol, ipratropium, just like asthma. Steroids, again oral usually, unless there is a problem with vomiting or absorption. Antibiotics if there is evidence of infective exacerbation. So please follow your local guidelines, but in atypical coverage with doxycycline and Clarithrol, depending upon the region. Obviously, if there is a high risk of resistance to clarithromycin, then azithromycin can be an option. But again, please assess the ECG and QTC interval for elderly patients. Again, antibiotics should be guided according to the local antibiotic or antimicrobial policy. Oxygen prescribing, strict saturation of 88 to 92% SATs, repeat the blood gases, and look for the signs of CO2 retention, and may require non-invasive ventilation. The role of theophylline is quite controversial. It used to be given, but now it's not considered as first line therapy or second line therapy because of the very narrow therapeutic window and risk of arrhythmias. And most of these patients have cardiac comorbidities as well, in addition to COPD. So usually it's not considered as first line. But again, please follow your local policies according to the to your local guidelines. Now this slide is really important. I cannot overemphasize the need for defining the escalation of care or the ceilings of care or the disposition decisions earlier on in the admission. In the UK, there is a lot of widespread practice of the respect form, which I think is crucial in determining such factors. So looking at the patient's comorbidities, age, functional status, expectations of the patient, and the overall outcome, all these decisions should be made in advance. So before we go to the ceiling of care, what are the ICU referral criteria in such patients with hypoxemia or type 1 or type 2 respiratory failure? So if anybody has a low GCS of less than 8 and is unable to maintain airway or appears to be exhausted, then that clearly is an indication for most likely intubation, provided that the patient needs ICU care and there is clear documented criteria. Also, refractory hypoxemia, despite using the non-invasive ventilation and high flow oxygenation, and also maximum inspired oxygen, whichever is possible, like 60 to 70% or up to 80% with non-rebreathing mask, and the patient is still getting worse or hypoxemia is not improving, that would again imply failure or futility of the non-invasive ventilation and would necessitate intubation. Severe respiratory acidosis, pH less than 7.25 despite trial of non-invasive ventilation would also imply that intubation is indicated. If there is hemodynamic instability, hypotension, shock due to any reason with associated dyspnea, that would also indicate ICU escalation for possible inotropic support, and also multi-organ failure, for example sepsis, pneumonia, multi-organ failure, that would require higher escalation to HTU or ICU. In terms of ceiling of care, as we discussed earlier, you need to establish the ceilings. Is the patient for full escalation? If yes, then obviously all the criteria on the left hand side apply. If not, then a ward-based ceiling of care is identified, for example. Then you need to decide about inotropic support up to 5 mics, antibiotics but no CPR, no intubation but non-invasive ventilation, and ward-based inotropic support, etc. can be done. If for palliative care, I think it's one of the important aspects which needs to be considered for severe advanced COPD patients, or severe pulmonary hypertension, or patients who are progressively getting worse over a period of time. So again, this has to be a multidisciplinary plan with pulmonology, with the primary physicians or the primary specialists who are looking after the patient. We'll touch on it in the next slide. However, the documentation of all these factors in discussion with the patient and the family is of paramount importance for all the reasons in this situation. And also you need to follow the local policies and guidelines of whichever hospital you're working, and the social situations, the cultural expectations, religious expectations, the societal parameters. I think all those have to be kept in mind, and also about the patient and the family choices, obviously in addition to the local hospital policies and protocols. So I cannot overemphasize that it has to be physician decision based on all these factors rather than one size fits all. I think it's always important to consider the palliative aspects of management of dyspnea based on the hospital protocols and policies. If you have determined the ceilings of care and the patient is qualifying for the long-term management of symptoms for palliation, then the palliative care team, multidisciplinary plan of discussion with patient and family, all those factors have to be considered. And a lot of non-pharmacological mechanisms or non-pharmacological means are available. For example, the positioning, calm environment, symptomatic management, and also looking at medications like opioids, which can reduce the respiratory drive and the anxiety associated with it, so gentle dosing. Similarly, benzodiazepines in selected patients also. So if it comes to this point, obviously you're requiring the use of palliative care team in addition to pulmonologists, the patient's primary health physicians, the GPs, and also the community Macmillan team can also be of vital role in this situation. However, this plan is usually achieved as a multidisciplinary outpatient plan rather than an inpatient decision about palliative management of dyspnea. Finally, we will be considering a lot of clinical integrated scenarios and clinical reasoning for dyspnea, this particular module, other modules in the upcoming video, which will be the exam corner, where a lot of these questions will be put into practice for MRCP exams, USMLE exams, and also clinical OSCE. So please stay tuned for the next video, which will come very shortly. And thank you for watching, and please do not forget to subscribe, like, and comment on the videos.